Hello and welcome to the COVID Symptom Data Challenge webinar. I'm Mark McClellan. I'm the director of the Duke-Margolis Center for Health Policy, and I'm pleased to be part of the set of organizations that are collaborating to bring this challenge, a very timely challenge for improving outcomes from COVID-19. We have partnered with Resolve to Save Lives initiative within Vital Strategies, with Carnegie Mellon University Delphi Research Group, and the joint program on survey methodology at the University of Maryland to support this COVID-19 symptom data challenge using an extensive data set provided by Facebook. The challenge, operated by Catalyst at Health 2.0, is looking for novel analytic approaches for using the COVID-19 symptom survey data to enable earlier detection and improved situational awareness of the outbreak by public health and by extension by the public, enabling more rapid and effective response. We've seen this work in other contexts. It's particularly challenging in the COVID context with the extent of asymptomatic spread, and we're going to talk about why this approach is therefore particularly relevant here. We are hosting this challenge because there are real opportunities, we think, to use these novel data to improve our understanding and awareness of COVID activity throughout the United States and globally, and help sharpen and increase the timeliness of our effective responses. So in this webinar, we're going to discuss how to better create situational awareness of the intensity of COVID activity in each of our communities, using data like this to help guide policymakers as well as businesses and schools, the general public, in making their decisions about containing the pandemic and getting on with their lives at the same time. We want to provide an overview of the COVID-19 symptom survey data, so you all can have a good awareness of what will be involved here. And we also want to describe in some detail the COVID-19 symptom data challenge itself. You're going to hear from some of the people who are involved in this and some illustrations of what can be done as well. We think that we can only understand the full potential of these additional data by engaging the academic and scientific community, including the growing ranks of citizen scientists who are trying to contribute to dealing with the pandemic effectively. So that's a bit of an overview of what I think you can expect coming during this webinar. And let me go ahead and challenge all of you. There I am on the screen too. Go ahead and challenge all of you to listen to how we're setting this up, to take a look at the data that we're going to describe and ways in which it can be used and why these are such important issues for containing and getting us through the COVID-19 pandemic. And then we'll go through some opportunities for you to hear about what to do next as well. So I just want to add my thanks to the other supporters for this effort in creating what we hope will be a true collaborative, if not crowdsourced, at least crowd contributed effort to make real progress on syndromic surveillance through some innovative data sources that are just now possible to deal with this really unprecedented pandemic. I think what we're going to do now is turn to discussion with Tom Frieden. Tom is a former CDC director, a distinguished public health leader in New York City as well, who is currently the president and CEO of Resolve to Save Lives. As I mentioned, one of the key collaborators on this overall effort, who has been making some very important contributions around issues of surveillance, detection of the outbreak, and how to respond to it, testing, and especially effective contact tracing strategies. Tom, really glad to be on with you today and really glad to have the opportunity to work with you on this important initiative.
Thanks, Mark. It's great to be here, and thanks for your overview remarks. I'll just say at the outset that data is really important, and more prompt data is life-saving. A few days or a week or two understanding the trends of COVID can make the difference between hundreds or thousands of lives saved and our ability to maintain economic activities as effectively as possible. And I want to give Farzad Mostashari the credit he deserves for being part of the essential ecosystem that created the syndromic surveillance world. We now take it for granted. And I can tell you that as New York City Health Commissioner, it was something I really valued. So when we had a couple of cases of bubonic plague in New York City, we were able to quickly do 12-hour cuts and see that there was no widespread increase in febrile illness in emergency departments in New York City. And that gave us a reassurance that we didn't have a huge outbreak. Similarly, when we had anthrax cases, we had that same assessment, and that gave us reassurance that we were not in the midst of a biological attack. And when the H1N1 influenza pandemic hit, we got tremendously valuable information from syndromic surveillance to get a sense of the scale and scope and location of the viral epidemiology as it began. And even when we had things like blackouts that were associated with food poisoning, we could make estimates of how much there was, where there was, and channel that into preventive activities. So I think the big picture is we think syndromic surveillance has enormous potential. As Resolve outlined in one of our science briefs, we have a weekly science brief that we think is pretty good and encourage people to sign up for, all free, of course, as everything we provide is. We outlined the data from New York City, which showed in early March a very strong signal in syndromic, which, if attended to, could have really changed the face of the epidemic in New York City and to a lesser extent in much of the US. So we're really excited by this data feed from Facebook, CMU, and UMD, and we want to see whether it can really be used to inform decisions at the national, state, and local levels, both in the US and globally. And that's why we're really excited about this challenge and look forward to seeing what comes in.
Tom, thanks for that overview of just how important syndromic surveillance can be. And I would like to come back to why perhaps it hasn't been even more effectively used to contain spread of COVID-19. But maybe first, if you could just spend a minute for everybody here, let's go back to the basics. Just what is syndromic data?
Right. So the traditional public health surveillance, which actually started, I have to say, in New York City in the 1890s, was you get a definitive diagnosis and you have it mandatorily reported to the health department. And you do that in real time, and then you follow it up with public health nurses to ensure that people are isolated or quarantined or treated so that you can stop the spread of disease, or you can figure out what is the source of disease. That's traditional surveillance. Syndromic surveillance goes a little further or takes a different approach and says, you know, it takes a while before we figure out what's causing a fever or cough or diarrhea. And why don't we look for those syndromes? And when we find clusters of those syndromes, we then can investigate and see, is it just a coincidence or is this an outbreak? That's particularly important for new and emerging infectious diseases because we may not know early on. So globally, we look at things like severe acute respiratory infections and what's happening with trends of those. But what Farzad and others developed some years back was a data feed from emergency departments that looked at the chief complaint. And whereas those of us who were traditional epidemiologists said, no, you should ask fever, yes, no, and have kind of a categorical responses, what Farzad and others demonstrated was that using the free text and analyzing free text was much more useful. And then using advanced statistical methods, SAT-scan and others, to see, is a cluster really a cluster or is it just a coincidence? Because if you've got lots of observations, it's inevitable that you'll have some that appear to be clusters. So you need a sophisticated statistical method to look at that. So syndromic is looking for syndromes, fever, cough, diarrhea, loss of sense of smell or taste. And what rapidly became clear is that with COVID, things needed to be tuned. So first off, we generally don't look at the number of people with the syndrome. We look at the proportion. That's much more reliable. It changes by time. And suddenly, if instead of 5% of your ER visits, 30% are for fever, something is up. That became much less reliable with COVID because people stopped visiting the ERs except for COVID.
Yeah.
So you couldn't measure that. Then numbers, which had been frowned upon in syndromic surveillance, numbers suddenly became more important. But this is also when we began thinking about what are ways to look at pre-hospital, pre-emergency room visits,
going well beyond the emergency room data and data that could potentially be accessed earlier.
And we had looked at this before, everything from school nurse visits to Google searches to looking for filling Imodium prescriptions in the pharmacy or Tylenol prescriptions to look for those signals. But Facebook provided a really interesting platform to think about, because you have people who are sitting at home and they might be willing to answer some questions. And that is the trigger for this whole project.
Great. Tom, I want to thank you for that overview and just a really fast introduction to syndromic surveillance and why it's potentially so important to do it differently now in the COVID-19 context, and what some of these new technologies like the Facebook platform potentially permits. Really appreciate working with you on this and so many other related efforts on addressing COVID-19. Thank you very much. I'd like to turn now to Alex Reinhardt and Samantha Chen, who are going to provide an overview of the COVID-19 symptom data. So Alex and Samantha, over to you all.
Great, thank you. And thank you both for an introduction to the project and the work we've been doing and to the problem we're trying to solve. So let me get right into it then and talk about what it is that we've been doing since April of this year. If we could jump ahead, I will tell you about so little context. So I'm a member of what's called the Delphi group at Carnegie Mellon University, which is for years worked on syndromic surveillance for influenza. So how could we forecast influenza epidemics? You know, every year the flu season comes along. And just as Tom and Mark mentioned, we did things like look at Google search trends to see people searching for flu symptoms, to try to get a handle on when the flu season would peak and so on. So beginning in March of this year, we developed a survey to ask respondents about their symptoms that are related to COVID-19. So a survey thinking, you know, if people in the US or around the world could say what symptoms they're currently experiencing, and we could do that at a large scale all the time, we might be able to detect cases where there's an increase in cases or something's going on. And beyond that, we could ask other questions important for public health about what kinds of behaviors, you know, are people going out, having contact with other people, all those kinds of things that might be important for making public health decisions. And Facebook agreed to recruit respondents and support the project. So they agreed, you know, we came to them and said, look, we'd like to run this survey, but for it to work, we need to get lots of respondents every day. And Facebook thankfully agreed, which was kind of a big leap for them since we're coming out of the blue and asking this. And the University of Maryland joined to implement an international version of the survey, which Samantha is going to tell you about in a few minutes. But first, I want to tell you about the survey itself and what we asked about. We could do the next slide. So here's the basic premise. Every day, Facebook invites a random sample of users to participate in this survey. So many of you may have seen this invitation in your own news feeds. A little thing pops up, like you see in the picture there, saying you can take a survey from Carnegie Mellon or from the University of Maryland. And the users are sent to a survey hosted by us on Qualtrics. So this is actually off of Facebook. Facebook does not receive the response data, anything like that. They do know who responded to the survey since they know who clicked the button. I'm going to talk in a bit about how they use that to help us correct for biases that arise from, you know, not everyone on Facebook takes the survey, not everyone is on Facebook, so there's some biases that arise there. So we at CMU and at University of Maryland collect this data, then we calculate aggregates. So we calculate, for instance, in this region, what percentage of people report currently having this kind of symptom. And Facebook has created a map you see there. We've also created separate maps at CMU and University of Maryland showing our data sources, showing all these aggregates so you can see what's going on around the world and in each county or each region or province. The non-aggregate data, the raw data, aren't publicly available because you could identify individual people potentially, but they are available to eligible academic and nonprofit researchers who want to study public health problems. So if you are interested in that, ask us about it. So what's on the survey? We could go on to the next. So in the United States, the two versions are a little different, but in the United States, the survey is available in 6 languages and English, and it has 5 sections. So we asked for consent to participate in research. We asked the participants, are you or anyone in your household experiencing any of these symptoms? And it's kind of a short list of the top COVID-related symptoms. Of course, they may be related to other things as well, influenza, other illnesses. But tracking these changes will help us see if something's going on. We also asked a longer list of, are you personally experiencing these symptoms? We asked some questions about contacts with others, your risk factors. It's not mentioned here, but we also asked about mental health. So, do you feel depressed or isolated? Are you worried about the effects of the pandemic? And we asked some demographic questions that help us break this down by age group or by different categories. And you can see sort of what it looks like for the people who get invited there on the right. So next slide. So every day then at the county level in the United States and for states and different divisions, we estimate several quantities. For instance, the percentage of the population with what's called COVID-like illness. That just means you have a fever and you have, say, shortness of breath or a cough or difficulty breathing. It's not specific, obviously. Someone in California in the wildfires right now who has a fever and is coughing because they're inhaling smoke would count as COVID-like illness. But as you can see here on the right, many of our indicators, you can see dramatic changes in them over time that correlate quite well with COVID cases. So actually the one on the right you see there is actually the percentage of people who know someone locally who is sick. And you see in Maricopa County, Arizona, it went from 10% to almost 40% among the younger age groups as the pandemic peaked there. And there's also numerous other symptom-specific averages available in the data for this competition. So if you want to know how many people had loss of smell or other specific symptoms, that's all available in aggregate. But I'd like to turn it over now that I've given the highlights of the US version, to Samantha Chu of the University of Maryland, who can tell us about the international version of the survey and how that's worked.
Thanks, Alex. Thanks so much, everybody. Just wanted to mention, I'm very proud of the international and global version of this project. I'm a PhD student over at the Joint Program in Survey Methodology at the University of Maryland. And in my past life, I was the past chair for business at Statistics Without Borders, and I've worked with hard to reach populations and conflict and crisis zones. And the effort that went into rapid turnaround and collecting such valuable data on symptoms for COVID have been very rewarding. So a little bit more about the UMD Global Survey Instrument. Next slide, please. The global and US surveys are fielded independently, though we've done our best to make the instruments as comparable as possible in some important ways. The University of Maryland's Global Survey Instrument is available in more than 50 plus languages, and the survey instrument has 5 sections. So you'll see some parallel with the US survey as well. We have consent, health systems, contact with others, as well as mental health and economic security and other demographic characteristics. I just want to mention, as the data was coming in, over the past several months, and also hearing about what was going on in different countries like Afghanistan or India or the Philippines, it was really worthwhile to see how the global survey instrument was tracking with what we were hearing from the ground. So the survey was developed in partnership with academics across multiple institutions in the US and abroad. And we received extensive feedback from the technical staff at the World Health Organization. The survey was translated by Facebook, which conducted an extensive translation and audit in addition to a back translation effort conducted by UMD. So this level of care and quality that I saw in this cross-national survey for the symptoms with COVID-19's like distinguishing issues such as difficulty breathing and how to translate that overseas was just taken into such detail for this project. Next slide, please. So as of June, we have received more than 20.3 million completed responses to the UMD Global Survey from respondents in more than 200 countries and territories globally, averaging 230,000 responses every day and 1.6 million responses every 7 days. And learning how to handle this much data could be a dissertation in and of itself, but it's amazing. On the US side, we've received more than 10.6 million responses to the Carnegie Mellon survey in the United States, averaging 71,000 responses every day and 500,000 responses every 7 days. So this really is an extensive data set for this challenge. Next slide. So something important I want to mention is adjusting for the sample bias. So Facebook provides analytic weights that adjust for non-response and coverage bias. By non-response bias, we mean that some of the sampled users are more likely to respond to the survey than others. To adjust for this, Facebook first calculates the inverse probability that sampled users complete the survey using their self-reported age and gender, as well as other characteristics that we know correlate with non-response in our web surveys. We then use this inverse probability to create weights, after which the survey sample reflects the active adult user population on Facebook for each geographic entity. By coverage bias, we mean that not everyone in every country has a Facebook app account or uses their account regularly. To adjust for this, Facebook adjusts the weights and created in the first step even further so that the distribution of age and gender in the survey sample reflects that of the general population. In most countries or territories, this adjustment also corrects for the distribution of the population across subnational administrative regions. What's also great is that making adjustments using these weights ensures that the sample more accurately reflects the characteristics of the target population representative. But still, I really encourage you and other researchers to consider whether or not further adjustments are needed for your specific use case. So, survey weights are available for 115 countries and may be revised by Facebook and its partners to assess sample coverage. We chose this set of weighted entities because of where we were confident we could provide high quality weights. This determination was not just based on coverage of the sampling frame due to social media use, but also based on other technological capabilities within these different countries. So it's important to emphasize that the weight value assigned to each respondent cannot be used to identify them. The weights are shared with UMD and CMU and only amongst other researchers who have signed and have agreed to the relevant data use agreements in place. All right, so we learned a lot about how to launch a syndromic surveillance symptom survey at scale. Next slide, please. There were numerous challenges to do the global daily tracking survey. I'll just mention some of them here, and then it looks like I'll pass them actually back over to how to access the publicly available data. So, for example, we had to have broad support across partners in the survey platform. The pre-testing was difficult to do some translation needs and changes to the sampling pipelines. We also had to take into consideration data access for GDPR countries and other data sharing and privacy concerns around the world to balance that level of legal concern. So I guess I'll pass it back over to Alex to talk more about the publicly available aggregate data.
Sure. So thanks. I will just mention a couple brief things and then we can head onwards. So I will just mention that we make, both CMU and University of Maryland make aggregate data publicly available through APIs where you can request any region's averages. And also for the challenge, it's not mentioned here, but on the challenge website, there are large aggregate CSV files available for download in the US. with all kinds of breakdowns and categories and aggregates for whatever you might be interested in out of the data that we collect. And if you want to use this for research, you want the non-aggregate data, we have some details here on how you can get access to it. All right, so I think that's it for us. So
Great.
I would like to pass it on then.
Okay, great. Thanks very much, Alex and Samantha, for that overview of the survey and how to use it. And Samantha, glad your dissertation is well underway as a result of the survey. Next, I'd like to turn to my colleague, Caitlin Rivers. Caitlin is a senior scholar at the Johns Hopkins Center for Health Security and an assistant professor at the Department of Environmental Health and Engineering at the Johns Hopkins Bloomberg School of Public Health. Caitlin has been doing an incredible amount of work academically and from a policy standpoint on the COVID-19 pandemic, to the point that I feel like I've gotten not only to know her well, but I know that her kids are not bashful about being on Zoom meeting calls. So Caitlin's going to describe some of the analyses that have already been done using the COVID symptom data. Caitlin?
Thanks so much, Mark. And unfortunately, I'm not able to share my video due to technical troubles, but I think we can make do anyways. So I'm going to talk a little bit about some of the analyses that have been done with the data, just to give you a sense of the kinds of things that are possible and to maybe inspire you to go ahead and dig in yourself. Next slide, please. So I'm going to talk a little bit about what we know so far, and the analyses I'm going to share are from a mix of the Delphi group. Alex Reinhardt, who you just heard from, is a participant in that group, and Farzad, and the people at Facebook. So we're pulling from a few different sources here. Next slide, please. The first thing to know, which we heard on the last panel, is that there is an extraordinary amount of data in this survey, and that really lends a lot of strengths that I think will be important in making this data as useful as possible to public health. There are tens of thousands of surveys completed every day. As we heard, globally, it's actually much higher than that. But suffice to say, there is a lot of data, and participation has held steady more or less over time, which is encouraging. Next slide, please. Now, just at first blush, you can see here that when you compare the percent of people with reporting COVID symptoms based on Facebook surveys with the average daily incidence or number of new cases of people with COVID, it really looks like there's something there. And so that was the starting point to try to better understand how these data could be used to better understand what's happening with our outbreak. Next slide, please. When you dive in a little bit deeper at the state level, there is a very high correlation at the state level with the percent of people reporting COVID-like illness and the number of daily new cases. This is particularly true in hard-hit states like Texas, Florida, Arizona, Louisiana, that were among the states experiencing the most disease during summer. And so it's important to note that there are particular indicators in these data that do have relevance to public health practice. Next slide, please. Now here's where I think it starts to get particularly interesting. Here we have 3 plots of reported COVID-like illness by 3 different outcomes: new cases, new hospitalizations, and deaths. And as you can see, in Florida, looking at new cases there on the left, there was a particular spike in COVID-like illness earlier in the pandemic when testing was not as widespread as it is now. And that is providing added value beyond the kind of surveillance data that we often collect as part of public health practice. For example, the number of new confirmed cases. We want this syndromic data to add something above what we would normally be able to determine from those traditional surveillance sources. And there's a little hint here in Florida in May that there may be room for that to be possible, which I think is very exciting. We heard from Tom Frieden earlier in the panel that oftentimes timely decision-making is absolutely paramount in public health. And so anytime that we can get an earlier warning or more confidence in those early decisions, the better off we'll be. Next slide, please. Diving in a little bit further, I believe this is Florida. Unfortunately, I forgot the label, but you can see over time, again, the daily new confirmed cases for COVID-19 tracks very closely here with the percent of people who know someone with COVID-like illness. So further evidence that there does seem to be a strong association in the data. Next slide, please. Now, what I think is particularly exciting is that at least for the counties investigated, the association can also be seen at the county level. Much of the public health data that is publicly available is only available at the state level. We only know, for example, cumulative tests done for many states at the state level. We don't have that sense of what it looks like at the county level. And so having data that allows a really detailed, geospatially resolved understanding of what's happening could provide a real advantage over what we know from publicly available data. And so I think the multi-level analyses that are possible with this survey data, again, are value add beyond what we have from a lot of traditional public health sources. Next slide, please. Another slice of the data that's available here that's not available using traditional sources, at least those that are public facing, are data related to age. Many of the public facing dashboards that you can look up in the United States, for example, have cumulative age trends, cumulative age plots, but they don't give any sense of how that's changing over time. We've heard a lot recently that college students, for example, are experiencing outbreaks, but it's not really possible to determine that from much of the publicly available data. The survey data that we have available to us now, though, can give a sense of how that's changing over time. And again, this is really important for public health practice to understand what's happening in the communities so that we can take really targeted interventions. Next slide, please. Now, I've shared here mostly daily new confirmed cases as the outcome of interest, but there's actually a number of different metrics that you could use to explore and find which are the strongest and which can provide the most value from the survey data. You could look at the percent positivity, which is the percent of lab tests that come back positive. You could look at hospitalizations and deaths instead of looking at all cases. We've seen a little bit from that COVID-like illness, COVID attributed all-cause excess deaths, and different calculated metrics of COVID activity. There's a lot of different outcomes to be explored here, and I've only touched on just a few of them. Next slide, please. And finally, I just want to circle back and reiterate why we care. It's because of public health and because we have an extraordinary opportunity here to use this unique data source to support public health practice during one of the times of greatest need in the history of public health. So what could we do with these kinds of analyses? We could identify outbreaks in geographies with low availability of diagnostic case data, places without good test coverage. We could differentiate between COVID and influenza using here Southern Hemisphere data. We could look at age-specific trends, discordance between perceived and actual COVID activity in a given community and time period, which is to say, if everyone feels like they know someone with COVID, to what extent is that true? And can that be used to kind of anticipate or identify early new outbreaks? And can we analyze the natural history of COVID infections and the temporality of symptoms? So there's a lot that's here that's very relevant to public health decision-making. And that's why I think exploring these data and putting them to their greatest use is a really important opportunity. I believe I'll stop here and turn it back over to Mark.
Caitlin, thank you very much for that timely overview of many of the potential applications of the COVID symptom data. So now that you've gotten an overview of the data and the motivations for using it, I'd like to turn the webinar over to Farzad Mostashari, who you've already heard about. He's the chair of the challenge committee, and he's going to talk about the details of the challenge. Farzad is the ideal person for this job. There's nobody better at motivating new uses and innovative approaches to data and analytics to deal with a critical public health problem. Farzad is formerly the head of the Office of the National Coordinator for Health IT, has that background in public health that you heard about from Tom earlier, and is a visiting fellow at the Duke-Margolis Center for Health Policy, in addition to his full-time job leading a very innovative primary care-based approach to delivering much better care at lower cost. So Farzad, thanks so much for taking the time to do this and walking us all through how to participate in the challenge.
Thank you so much, Mark, and thanks again to the Duke-Margolis Center for hosting this challenge. I'm going to talk to KX, and goes by KX, about kind of why do we feel like we need to do this challenge. And for me, when I first heard about this idea, I was a little skeptical. And I think KX may have sensed my skepticism. I was like, yeah, you know, people responding to surveys. There's a lot of, you know, question about who's on these things and why someone would respond, and you know, can we trust this information? And then I heard what you guys just heard, 30 million, 30 million survey responses, and a design that allows for weighting of those and comparison over time. And my next thought was, why isn't everyone using this? So KX, why isn't everyone using this? Oh, you're on, I can't hear you.
All right, let's try again. How's that? Awesome. Well, thank you for all of your work on this challenge. Just a little bit of context. So the Symptom Survey is part of Facebook's broader Data for Good program, which has been around for a few years now. And through that program, the goal is to work with a network of researchers and academics from around the world to really just support public health efforts. So this program existed before COVID. It includes things like our disease prevention maps program, which shares aggregate insights around population mobility patterns and trends, as well as a lot of our survey work, both symptom surveys, preventive behavior surveys, and a few other things. So it's been really, you know, I'm really grateful to be able to work on this program, and specifically with symptom data. But I think more generally, one of our main learnings here is that the feedback loop and iteration around the data is extremely important. You take mobility data, which is one of the more mature programs. It's been around since 2019, so over a year and a half. You know, initially, we didn't actually realize the potential positive impact of having these aggregate data available until we got feedback from public health experts a year and a half ago. And then after we got that feedback, we worked together with them, technical experts, as well as pharmacy experts, to figure out how to enable this. And the first version of the data we released were definitely not as good or useful as where it is now. And obviously, we've continued to improve and refine that over the past year and a half with a real acceleration post January. And I think we need to do the same thing for surveys and for symptom surveys in particular. It's an earlier data set, right? We're only 4 or 5 months in, and we're trying to really accelerate that feedback loop so we can work together to figure out how to make this the most useful as possible for folks.
Let me ask a provocative question. If you don't see this data put to use, do you think you're going to continue to push hundreds of thousands of sample to these surveys next year this time?
Yeah, it's a great question. I mean, ultimately, we want the data and the programs we use under Data for Good to have the biggest possible impact, and we're tremendously optimistic about the impact it already has and can going forward. But I think that's one of the goals of this challenge and some of the other work is to learn, like, where is this really useful? Where is it not? And we obviously want to focus on the places where it's useful, right?
So over the weekend, you and I were doing some amateur epidemiology. What's your sense of, you guys have made this open, right? And it wasn't, you know, the approach wasn't to say we're gonna pay some august institution to analyze this data. We're gonna create an open API and anyone can tap into the aggregate information on that. What is your expectation in terms of the grad students, the college students, but also just the citizen scientist, the has-been epidemiologist sitting in his basement like me? Do you think that there's the possibility that someone, some you know, gal sitting in her basement is going to come up with the analysis that wins this $50,000 award?
You know, I think one of my learnings over the last year, and especially over the last 6 months, is the importance of interdisciplinary approaches, bringing in complementary expertise and strengths. You take the, whether it's mobility data or our symptom surveys, it's not like any one group had the complete picture, right? Like, we are bringing our unique reach and sampling, but a lot of the motivation came from other folks, as you've heard earlier. And I think that's also true in learning the application and value of the data. So we're quite excited to see what comes out of this challenge.
I am too. Thanks so much, KX, for your work on the Data for Good project, for making it possible for this data to exist, and then for your sponsorship of the challenge.
Thank you. I'm grateful for the people who have participated in the survey. I've been surveyed once myself and filled it out, and I'm looking forward to supporting the experts and learning how best to apply these results to help with the public health response.
Thanks, KX.
Thank you.
We're now going to turn to the actual nitty-gritty of what does this challenge operationally look like, and what are the next steps in terms of you, we hope, are one of the folks who want to download the data, or maybe you've already downloaded it and you want to have a go at winning this challenge and the everlasting fame that comes with it. I will turn you over to Indu Subaya, who is the president of Catalyst Health 2.0, who's helping us run this challenge.
Thank you, Farzad. We're delighted to support the administration of the challenge here at Catalyst at Health 2.0. Just a little bit about us. We've been working for over a decade now, running innovation challenges, and have been able to provide, on behalf of partners and sponsors, over $9 million in funding for teams, entrepreneurial teams, to build and scale their technologies. So we're delighted to be here and to support this particular challenge. Next, please. So a few important dates for your calendars if you're considering applying. The first is that the phase 1 application submission deadline is September 29th. At that point, teams are invited to submit their first pass analytic approaches. And then on November 6th, 5 semifinalists will be chosen to do a virtual unveiling in front of a very, very exciting panel of scientific judges and people that really have the qualifications to evaluate these submissions. You heard KX explain the multidisciplinary aspect of this. And so we're going to have a pool of folks with a wide range of expertise to evaluate. From there, we go on to phase 2, where up to...
If I could ask you a question. If someone who is listening on this webinar or later on listening to this recording says, you know what, I don't think I want to be a contestant, but I think I'd be a great judge, how can they volunteer for that?
Please email us at innovate@catalyst.health, which is an email I will show at the end of this webinar and will be made available to all attendees. We are looking for judges, and you can join any number of panels, the phase 1, the phase 2, etc. So please do contact us. So we will have that first phase evaluation on November 6th, and from there, up to 3 teams will advance. And possibly up to 5. It's going to depend on the quality of the submissions. Up to 5 of them will advance to have time to develop a prototype, a simulation, or an actual visualization of how the analysis will work. And those will be judged on December 7th in front of a very targeted group of decision makers who might actually end up being potential partners for the deployment of these analyses. And so you can find this entire process on the Catalyst Health's website for the challenge. So we can go to the next slide. And you can follow along the timeline and the phases. And of course, because we know this will take hard work even to get to phase 1, the 5 semifinalists will each win $5,000 for their efforts to get there and to be chosen to be semifinalists. And from there, when you advance to the final round, the winner gets $50,000 and the runner-up will get $25,000. And we really believe, and the work that Callis and Farzad and we have done together, that the challenge is to demonstrate the proof of a brilliant new approach, but the work lies ahead in how we actually get it used by all the jurisdictions that need this very important data, and we're there to help with that. And so if you go to the next slide, please note, you can email us at any time. We're on Twitter, via email, and we can be reached on the next slide as well to please go to the website. Everything that you need to know is there. And if it isn't there, there is an email to contact us. There is a Slack channel you can join to be part of this incredible community that already has a number of members, and you can follow along with all of the deadlines and all of the submissions, as well as announcements for events like this, where we'll be talking about the data. So thank you so much. Farzad, back to you.
Thank you. I mean, I've been involved in public health surveillance for a long time. That was kind of my first love coming out of fellowship at the Epidemic Intelligence Service too many years ago, over 20 years ago. And I'm pretty excited about the symptom data, but I think as scientists, we have to be always somewhat skeptical. And we always have to consider the possibility that this is not going to add any supplementary additional information in terms of utility. And that's the question that we're trying to answer. The winning submission might be someone who says, based on the best evidence I can put forward here, the most compelling argument is, no, this doesn't add value above and beyond the data we already have around case counts, around hospitalizations, around deaths. But I think that we don't know until we give it our best shot. Because we know that our current data are flawed. We know that case counts, as Tom said, are very much dependent on testing. And if you are in parts of the world where there isn't the testing capacity, or if you're in parts of the world where there isn't a systematic approach to testing, and we're seeing big shifts in who gets tested and how many people are tested, then that data can be quite misleading. We're looking through a lens. Syndromic surveillance with the kind of the methods that I and others worked on 20 years ago that are now traditional syndromic surveillance from emergency rooms, that's through the lens of health-seeking behavior. And as Tom said, when people change their health-seeking behavior, that can be clouded. And deaths, well, deaths are a hard reality. They can still be underestimated. There's one of the pieces we linked to is Dan Weinberger's lab and their counts of weekly counts by state of excess mortality. But that's really, really delayed. You can't wait until people start dying before you do your public health response. So the current data we have are all flawed, and this really, I think, analyzed the right way, the signal to noise could be magnified to figure out what is the best and highest use of this information. I think if we can continue to show that value, then it should be there on in the pantheon, right? It's not the only thing we look at, but if you were going to look at, the Hopkins site or the New York Times site or the COVID tracking site, why not have right there next to it some signal that comes from or integrates with other data to give us a better situational awareness of what's happening? That would be success to me. And I think that would be sufficient to have this effort continue to be supported. And I think KX was very generous in terms of his take on this. But I think this is costing resources. It's not just Facebook's resources or CMU's resources. It's people's resources filling out these surveys. And we should not continue it if we can't show that it's adding value. I believe that we will, but that is the question that we have to decide together. So let's take a look at some of the questions that have come through, and I really encourage, we have a little bit of time, I really encourage you to put your questions in the chat. If others afterwards, if you have questions, please put them at innovate@catalyst.health. We have lots of ways of engaging with this challenge. The challenge website is symptomchallenge.org. There's a Slack channel that's on the front homepage there. We would love to have discussion, team building, community building around these questions. I love Twitter as a medium for communicating and for sharing insights. Farzad_MD if you want to. But let's take a look at what some of the questions that have come through on the channel already. And maybe I'll ask actually Alex Reinhardt to answer this first one. Someone asks, may I ask please for more detail about the way the adjusting weights are calculated? Is there a paper that describes the methodology?
Yes, actually, that so Facebook was working on writing up documentation so that everyone could understand how the weighting procedure works. And we posted that actually just a couple days ago on our survey website, and we can share it the challenge as well. But yeah, so there's a procedure based on demographics as well as Facebook's estimated probability that you'll click on the survey and continue. The aggregates we made available for the challenge, we have weighted aggregates in there already, so they're already, the weighting is calculated, and we gave you the weighted number if you want to use it. But data is available on CMU's survey website, and I think the documentation is available on CMU's survey website, I think soon on Maryland's, and maybe I can post that link in the Slack channel or somewhere else for people to find as well.
Thank you so much. And jumping ahead to I can answer another question on the Slack channel. No, the weighting does not account for whether you think COVID is a hoax. That is not something that is used in the weighting. All right, can we access the non-aggregated data? Alex, you already touched on this.
Yeah, so access to non-aggregated data is available if you are an academic or nonprofit researcher working on, public health, important problems like that. All you need to do is agree to an agreement that just says you're not going to release individual survey responses that might identify someone, only aggregates and summaries and tables, that kind of thing. But that's available on our website and Data for Good website. You can see the form that's needed.
But I will strongly encourage you, before you engage in the process of getting access to the line level, take a look at the data that we've made publicly available through the APIs, but also we made a really easy CSV to download that contains just an unbelievable wealth of information on all the questions that are there. There's county level cuts by week, there's state level, there's weighted and smoothed data sets. Just I was playing around with it this weekend. It's really there's a wealth of information there. So for the purposes of the challenge, we are asking folks to look at those aggregated information. Another related question: if researchers request the granular non-aggregated data for the challenge, can they do it can they participate in the challenge deadline? Again, we're asking for the challenge, everyone, we want to be on the same footing, so use the aggregated data for the challenge. I think our hope is that we will continue, as KX said, there'll be a feedback process, and those who are really great at using the data and our challenge winners will help us improve the signal to noise on the challenge. But let's start with the CSVs. It's incredible. Is any information available on the demographics of people most likely to fill out the survey? Men 18 to 34, Alex, they don't seem to click on it as much as women, who are older, but you have ways of controlling for all of this.
Correct. So Facebook in their survey weights tries to adjust for age and gender to ensure the age and gender in the survey matches whatever the state or province or regional population is. So, I mean, if that population has a certain age distribution, we'll try to ensure the weights match that. I will say, when we chose those age splits in the aggregated data, the age buckets are actually about equal size in terms of number of respondents in the US. So it's not, only young people answering the survey, for example, like you might initially guess.
Exactly right. Once again, people are saying, how do I get to the data? Click on symptomchallenge.org. there's a section there on data access, and that'll take you to the CSV of the different, both international will be coming shortly. The CMU US-based data is there now, and we're going to be doing an update of the data 2 weeks in. We'll give an update that includes the most up-to-date information halfway through that time. All right, and this is probably going to be the last question. Any other questions? And then just to clarify, back to Indu. Indu, tell us about the money. How does the money work?
So there are several opportunities to earn some much needed cash right now for folks. The semifinalists will each receive $5,000 because we understand just getting to that first phase is still a big deal. And then the people that advance to the final round, the winner gets $50,000 and the runner-up $25,000. So this is, we hope, real money for folks who are committed. And I do encourage everyone to go to the website, join the community. I want to make a plug again for the Slack channel. You can email any of your questions to innovate@catalyst.health about the challenge, how it's structured, if you're confused about how to get to the data. There's even a form on the website that you can be notified early as soon as new data are available. So you will see that under the data access section of the website. So we're thrilled, we're excited. We've already seen a great response from the community, and we just encourage everyone to come together.
That's a lot of pizza. I strongly encourage, in particular, our public health students, our computer science students, stats. We've had some great analyses from folks who are in the physics community, people who know data, who care about these questions. Please participate, and we would love to see the best thinking you can contribute to our country. Thanks again. With that, I think we can close out today's webinar. Indu, any final words?
Thank you for joining, everybody. And like I said, we look forward to seeing you on the Slack channel or on email if you have any questions. And this recording will be made available so you can watch it again. I know there was a ton of great information. Thank you, Farzad, and to everyone that joined today.
Thanks, everyone.